Good afternoon to everyone present here with us today. This is Shreyon from IGCP. I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared, our keynote speaker doctor for today's session. With much pleasure and honor, I would like to welcome a very renowned Padma Shri Dr. Moshin Wali. Sir is a senior consultant of general medicine at Sri Ganga Ram Hospital at New Delhi. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is current challenges of selecting right medicine in hypertension. Now, without any further delay, I would like to welcome Sir to our forum and would like to hand over the session to him for his precious talk to begin with. Over to you, Sir.
Thank you, Shion. I'm sorry for the delay in starting the session. As you know, always on Monday, there is traffic snarls. And this topic I chose because there is a lot of marketing of newer antihypertensive drugs and pressure amongst the doctors, especially practicing doctors, what to do, what to prescribe. And doctors are being dictated to prescribe certain medications. Just 2 days, one senior correspondent from Hindustan Times is calling me, and she said, I have got leg swelling. I discovered she is on amlodipine. So these are the examples patients get worried about some effects. It's of course not the very severe side effect, but it is an effect of amlodipine of leg swelling. So she is worried. Some doctor told her on phone that get your kidney tested. So these kind of things are happening. So we have to know better drugs, and we have to know which drug would be ideal for which age, which sex, which group of people. Like we have diabetes in India combined with hypertension, heart disease, kidney failure. So all these combinations take us to this topic. I will give certain examples. And this first case is 40-year-old farmer, simple farmer. We don't expect much of cardiovascular disease in him. And he was worried. So a lot of anxiety, but hypertension. 145/90, it is treatable limit, 90 above 90 and 130 above 145. No diabetes, no smoking, no alcohol. He's a farmer, no family history. So I am starting with a simple example. Treat him with amlodipine unless he does not show improvement. So amlodipine today is the most commonly prescribed calcium channel blocker. It lowers blood pressure gradually, well tolerated across all age groups, and no adverse effect on blood sugar, relieves anginal symptoms. When this drug came from Pfizer, I was in Rashtrapati Bhavan in 1990, and this was per tablet more than 36 rupees, I remember, and now it's so cheap, it's 2 rupees, something like 2 to 3 rupees. So on long-term treatment, amlodipine reduces the left ventricular hypertrophy. It causes cardiac remodeling, which is associated with hypertension. Now, case number 2. Here is a smoker who is young, 39 years, male, presented with history of diabetes for last 1 year, recent onset diabetes, and is non-compliant on diet. And he has headaches occasionally. LDL is high, HDL is low, HbA1c 7.2, blood pressure same, 145/90. But this individual is a smoker. He's newly diagnosed diabetic. So we have a better choice for him. That is telmisartan, and along with amlodipine. So this is the example. I'll come to the details why we are choosing this. And just excuse me. So, and then anti-diabetic treatment, simple treatment, glimepiride and metformin. And of course, this lipidemia we have to correct, and we have to give rosuvastatin. I will tell why rosuvastatin. And this is like a simple example. So telmisartan, today it is, I think, most prescribed drug and is a preferred antihypertensive. It gives 24 hours consistent control with systolic reduction of 15, diastolic reduction of 10, and is very good for new onset left ventricular hypertrophy. Over the years, it reduces 35 to 37%, 33% reduction in proteinuria progression, because if you test microalbumin in these patients will be high. So advantages are gradual reduction of the blood pressure, 24 hours good control, offers protection to the heart, protection to the kidney, good for long-term use, absolutely negligible side effects. And insulin resistance is also being dealt with in obese patients. This is ideal. So amlodipine and telmisartan combination, a word about it. According to American College of Cardiology, American Heart Association, European Society for Cardiology, European Society for Hypertension, International Society for Hypertension's guideline 217, 18, and so on. Telmisartan improves sensitivity and helps improve the control of glucose. That is, it reduces, I have shown, target organ damage in the vessels, in the brain, in the heart, in the kidney, in the eye. It is a preferred angiotensin receptor blocker in diabetes. Because diabetes is growing, we have to prescribe amlodipine plus telmisartan. It offers target action protection. As I said, both drugs reduce blood pressure once a dose, and the patient is compliant, so we can give safely. Then a word about glimepiride and metformin combination. Glimepiride and metformin combination is somehow very beneficial, and about 3/4 patients, 70% patients, they achieve glycemic control. By the month end, this combination reduces blood sugar quite a bit. And as you see, the baseline from 160 to 112. So it's a very good control. I'm just moving my image so that I can have more space on the slide. Okay. Now I'll complete this screen. Yes. So this what we have seen is a very good, of course, in our OPD, patients don't come with sugars like 163, they come with 400, 450, and they're surprised when you diagnose and tell them you are diabetic. They say, I was fine, I'm fine. And they keep walking with the high blood sugars and they don't care. Then we have another category of elderly hypertensives, like 65-year-old, this female presented with old case of uncontrolled hypertension, reports having been diagnosed with angina 1 year ago. This is, remember, postmenopausal lady. She's non-diabetic. So atenolol is the drug. Here, we don't have in males the danger of sexual dysfunction or other side effects of beta blockers. So we can try with the dose like 50 milligram with amlodipine. And in doing so, we can reduce the dose of amlodipine also. And this is a combination therapy preferred when two drugs with different mechanisms of action are required. It improves patients' compliance, and we can give a combo, two drugs in one tablet. So this is third example. Now, amlodipine and ethanol, this was the drug of my preferred choice till 10 years back because it reduces heart rate, it gives more time for the heart for diastolic filling, therefore reduces angina, protects the heart, and 80% reduction of the heart rate, 32 millimeters systolic, 18 millimeter diastolic blood pressure reduction, and I have the difference. Then hypertensive, uncontrolled patients on monotherapy, like this 45-year-old male presented with a known case of hypertension who is a smoker, note down, smoker, alcoholic, asthmatic, no angina MI. So far, he complains of ankle edema. That means he is in failure. 160, 100, I don't know for how long. So we have to add diuretic with telmisartan, ideal combination. So here comes the need to add diuretics. They reduce the afterload, and they increase the cardiac contractility, cardiac function, decrease edema, decongest the heart, decongest the lung, reduce the swelling. So hydrochlorothiazide combined with telmisartan is a very good synergistic combination, effectively controls blood pressure in young as well as elderly population, safe in old as well as young population, blood pressure reduction on an average systolic 24, diastolic 11, plus minus 15 to 12.3. So this is a very good picture. When you see the four scenarios, we have to take some tips out of these four cases. What are the factors to consider while making choice for an antihypertensive drug? I have made the case very simple. Consider the age, weight, diabetes, heart disease, history of CAD, other drugs taken, Sometimes in the olden days, people used to take ibuprofen for years together. Old people walking in CGHS OPDs, they're carrying prescription, taking ibuprofen for 5 years, 6 years, 10 years. This was the scenario in my OPDs, CGHS, heavy OPDs in RML hospital. And now we see the lipid profile. Many of us have very dearient lipid profile, especially youngsters have dearient lipid profile. So safety tips for choosing drugs are patient's profile. If the patient has got raised creatinine, then we have to avoid all these group of drugs: ACE inhibitors, angiotensin receptor blockers. Patients who are a smoker, we have to avoid beta blockers. Patients who have got Raynaud phenomena, we have to avoid beta blockers. Prefer ARBs, ACE inhibitors, calcium channel blockers. Patients who are diabetics plus hypertensives, prefer ARBs, ACE inhibitor for renal improvement, renal function improvement, and to avoid missing symptoms of hypoglycemia. Beta blockers do mask the symptoms. When should monotherapy or combination therapy be used? Next question. So the expected mean blood pressure reduction in monotherapy is overall between 10 to 100 millimeters systolic and 10 and 8 diastolic. Drugs combinations at average high doses, I will correct myself, I think this was 10 and 15. Yes, I spoke correctly. So 10 and 15 and 8 and 10. Drug combinations at average high doses of achieves blood pressure reduction ranging from 20 to 25, 10 to 15 systolic and diastolic respectively. You can understand this is not a complicated statement. Reductions in systolic, diastolic blood pressures, systolic more than 20 reduction, diastolic more than 10 reductions are very unlikely to be achieved with monotherapy. And at times we want more reduction. Suppose patient is walking in my OPD with 170 by 100 blood pressure. Of course, I will have to give heavier doses than mentioned. So quick decisions. Young, newly diagnosed, ARBs like telmisartan, calcium channel blockers. Diabetic hypertensive, first drug of choice, telmisartan, with or without. Or second choice, calcium channel blockers. Patient with heart, history of coronary artery disease, MI or heart disease, telmisartan. Second choice, calcium channel blocker. Here diuretic will be very good. Elderly, calcium channel blocker. If creatinine is normal, ARB. Monitor creatinine regularly, can give second choice. Elderly beta blockers. As I mentioned in the previous slide, patients with angina. Here, beta blockers in divided doses would be very important. ARBs, telmisartan is safe. Calcium channel blockers and calcium channel blocker with amlodipine would be second choice. So here are examples. Amlodipine, clindapine, azelnidipine. These are the examples of calcium channel blockers. In young, they're first line. Like amlodipine is the common first choice. In old, can be first line drug. Amlodipine is the common first choice. No adverse effect on serum creatinine. Safely give amlodipine. ARBs like olmesartan, valsartan, telmisartan. All these drugs, including enalapril, lisinopril, ramipril, first line. In young, yes, it offers good cardiac traction. More than 60 to 65. Please check kidney function. This drug can cause increase in the creatinine. Then beta blockers, we are using now metoprolol, nebivolol, and also selective like carvedilol. So with this young patient, avoid as first line because some of the patients can complain of cold legs or they can complain of decreased in libido, can cause intense fatigue. Old age, please consider avoiding. Advantages: reduce heart rate, reduce angina, as I said, palpitation. Diuretics, unless indicated, avoid it at night. And it is better to give diuretics if the patient has got a cardiac history. So commonly used diuretics are furosemide, chlorthalidone, indapamide, amiloride, all these diuretics. So patient with a history of heart attack, all these calcium channel blockers are good. First choice can be ACE inhibitors. They improve the cardiac function. In some cases, I have seen they increase ejection fraction. Beta blocker can be used as first choice because I have explained the reason. They give more time for the diastolic filling. Disadvantage is that they can cause hypoglycemia, unawareness in diabetic patients because masking of symptoms like sweating is not taking place, palpitations are not taking place, the patient is not aware of hypoglycemia. Now, what are the practical tips? Some practical tips in the titration, up titration of antihypertensive drugs. If you are giving monotherapy, start with a low dose of amlodipine. In India, we can start 5 milligram because patients doesn't come to us early. Call for follow-up after 1 month and check up. If controlled, continue same dose. If not controlled, increase the dose, up titrate the dose. What I mean with that, 5 milligram is an average dose. Safely can be given. Call for follow-up after 1 month and recheck blood pressure. If the blood pressure is still not controlled, give combination therapy, especially in this season when the winters are approaching. We have to call all the patients who were controlled in summers. Maybe we have to increase the dose of the summer antihypertensive drug and we have to step up the therapy. So start with low dose. If BP is not controlled, do not too much uptitrate the drug. See the other factors like anxiety, lack of sleep, smoking, and some drugs like licorice. People are taking a lot of salt. Nowadays, I always tell them not to use potassium containing salt, but use the common salt. A lot of patients are coming with high potassium who are on ACE inhibitors or who are on angiotensin receptor blockers. And I find that they are using senda namak. Very practical tip I am giving all of you. Senda namak has got low sodium, and sometimes people take trade names of low sodium salts. And they are very fascinated that we are taking this instead of salt, but subconsciously they are increasing their serum potassium. It is dangerous for heart and kidney. So in obese patients, if the body weight is high, telmisartan, uptitrate. If the body weight is normal, low dose of telmisartan. Now, here is a logarithm of what we have talked so far. If the systolic blood pressure is 145, diastolic is 90 and above, then prescribe first amlodipine, increase to amlodipine dose. After 30 days, add telmisartan. If not controlled, after another 30 days, increase, uptitrate the drug. First, telmisartan should be increased, and then diuretic can be added if the still blood pressure is high. And diuretic can also be increased if you find there is a swelling, not due to amlodipine, but due to back pressure of the heart or incipient congestive cardiac failure, heart failure with reduced ejection fraction. It is very useful to add diuretics. And this Indian our Indian hypertension control, our initiative, IHCI regimen is recommended by the WHO, Government of India, Health Ministry. They agree with what recommendation I am talking. So go ahead and prescribe these medicines. Then if the systolic, this is same slide. And then points to note are women who, this is another very important scenario. Pregnancy. Do not give telmisartan or chlorthalidone because they can affect the kidney function and also reduce the blood pressure if low. Then what you have to do not give telmisartan or chlorthalidone, statins, ACE inhibitors, angiotensin receptor blockers, and thiazide like diuretic should not be given to pregnant women or to the women of childbearing age, not on effective contraception. Calcium channel blocker can be used. If not controlled with intensification dose, refer to specialist. I mean, they will do these drugs, which are old time drugs, labetalol. Previously, we used to give alpha-methyl dopa. Still, some doctors use, but we avoid diuretics. And we can add beta blockers to amlodipine with initial treatment. If there is a cardiac history or there is a history of diabetes, control the diabetes first. And BP should be targeted less than 140/90. I would say further less than 140/90, like 110/70, 120/70. If there is a history of a stroke or heart attack ever, begin low dose of aspirin and statin. Do not avoid this due to the risk of pregnancy. People with high CBD risk consider aspirin and statin. Chronic kidney disease in pregnancy is a very, very difficult situation. Patients can go in eclampsia, preeclampsia. So all this, and side by side, we should do lifestyle modification. Tobacco in any form is no, alcohol in any form is no, exercise and healthy diet, no fried foods, and reduce the weight if patient is overweight, 5 serving of fruits and vegetables, salads like things per day, papad which contain high sodium, chips, chutneys, achars, dips and pickles, all these should be avoided. Healthy oil should be used. Sunflower oil, mustard oil, groundnut oil, safe oil should be used, which are having low saturated fatty acid content. Remove the fatty part of meat. Use vegetable oil, boil, steam, or bake instead of frying. Limit the use of oil. We have got air fryers these days. No oil frying mechanisms. And trans fat food should totally be avoided. No samosas, no thing, nothing like that. No chaat, no further fried food. I'm on the seminar. So we should be very careful while dealing with pregnancy. So here is a very simple plan. You can say WHO and Government of India prefer amlodipine and telmisartan combination in grade 3 hypertension in patients with high blood pressure, grade 3 hypertension. Single pill combination therapy should be used. Treat adults with BP more than 180, 110, grade 3, with or without comorbidities such CVD, diabetes, or CKD. Start two-drug combination therapy, preferably in single pill combination. We have these pills combinations. And then consider beta blockers in patients with angina. In the case of heart attack, past myocardial infarction, beta blockers will reduce the heart rate and workload on the heart. Follow up monthly after initiation or a change in antihypertensive medication until patient reaches blood pressure target, and then targets like less than 130 systolic blood pressure. I'm making things very simple. Remember, 130, 80, 130, 80, 130, 80. Safe range for all groups. Follow up every 3 months with blood pressure control. So if the blood pressure is not at goal, again, you can refer to the specialist. And these are the cases of difficult to treat hypertension or resistant hypertension. We have to investigate in females, hypothyroid, in males, 24 hours urinary catecholamines, something like adrenal related cause or severe anxiety, sleep apnea, patient taking licorice or extra salt, and patient non-compliant to the medication. This is same slide. Now, tips to improve the blood pressure are most importantly, reduce salt intake. Don't abstain salt. This is very important. And do not use Seda salt, pink salt. Use the rock salt or simple white, this type of salt, which is called crystal salt or Dela Namak. Eat a balanced diet. Put enough space for fruits, but if the kidney function is compromised, please do not take potassium containing food like people take a lot of coconut water, a lot of bananas. Avoid them if you have impaired kidney function. Smoking in any form, tobacco in any form is absolutely no. Alcohol, we have a debate on whether we should consume a glass of red wine, 2 glasses of red wine. But for today's talk, when we are talking about medication, no to alcohol, limit its intake, be physically active, maintain a healthy body weight. What I have seen, people who are disciplined eaters, they don't have all these lifestyle problems. The problem comes when we are not disciplined. Today I was coming out of hospital. I saw a obese lady still munching something in the hand to eat. What is the need of eating, walking in the hospital? And you're putting on weight. And obesity is so evident. I have never seen a thin person eating while walking in the hospital or elsewhere. I have seen people, their plates in the dinners. I have taken the photographs of sane people. They take very little food in their plates. They don't go for huge amounts of servings. So take a small meal, be disciplined, decide how much you have to eat and take it in one serving. I will talk further about it. Stress reduction is also very important while we treat the hypertension. And this today we are talking about mindfulness, medication is the best stress reliever, yoga, deep breathing. If you can't do anything while you are sitting, take out 5 minutes, do deep breathing, close your eyes. Then you imagine, visualize some greenery or something nice, flowers, mountains, birds. Then progressive muscle relaxation. It's if office going people need to stand up and walk in the office after every 30 minutes. Like I see the patient, I sit from 2 to 6. It's very difficult to remember this. You are busy and the clock is ticking and you forget that you have to straighten your knees, you have to straighten your back. So 30 minutes of daily of moderate exercise, 150 minutes a week without 2 consecutive days missing is the recommendation of American Heart Association. Now, this slide I like. This is the tip of the pyramid. This is the base of the pyramid. You go towards the tip, you will find sweets. So you start from the base, remain at the base. Best is at the base. 8 to 10 per day vegetables or fruits, then grains, then whole wheat, bread, low-fat dairy products, seafood, those who take non-vegetarian, clean meat. Take care of your oils, what sorry, what you are eating, what you are serving, what you are cooking with. Then beans and nuts are very good. Some people don't believe in it. Yes, you should take walnuts, very healthy. Pistachio you should avoid. Salted pistachio you should avoid. Cashews, yes, in a small quantity. And again, I'll say out of this, if you ask me what's the safest, I would say walnuts. Now, at the top, sweets, very important. We are very fond of sweets, especially in dinners. So, what is a serving? Half cup low-fat fruit yogurt, or half cup, 1 cup low-fat fruit yogurt, or half cup frozen yogurt, 1 tablespoonful any syrup, sugar, or jam. Avoid cold drinks. Cold drinks, totally no. Now, the big thing, compliance. People forget to take medication. Or sometimes they go to see the doctors. They say, since I was coming to you, doctor, I did not take medicine. As simple as that. Every patient should be counseled, especially when the sons come with their fathers. I find son is obese, father is normal weight. I make the father sit down and I ask the son, you are a bigger patient than your father. Please let me see you first. Go out, get your blood pressure checked. And I find 80% cases they have these youngsters who bring their parents, they have high blood pressure. And this is very important to spot before they have any symptoms. And as we know, hypertension does not give rise to any special symptoms except occasional palpitations, headache, lack of sleep, breathlessness. So control of blood pressure with drugs, diet alone or exercise alone may not be sufficient. Maintain normal blood pressure, continue medication, especially in northern India, get your blood pressure, start checking your blood pressure, monitoring your blood pressure. When the Deepavali comes until March, April, keep it under check. Maybe after March or April, you might have to decrease the medication. BP lowering medicines, yes, very important question. I am not taking doctor blood pressure medication because I will get used to it. Sorry, you have to take medication lifelong if you have blood pressure. Exercise 30 minutes, walking, swimming, running, any exercise, deep breathing, yoga, pranayama, relaxation, meditation. But active exercise, muscular exercise, as I said, 150 minutes each week or 30 minutes a day with no 2 days of abstinence is recommended. Diet must contain plenty of fruits, vegetables, pulses, If diabetic, avoid mango, chiku, sweet lime. Take limited fruits, papaya or apple. So lose weight, monitor blood pressure regularly, do not smoke, avoid drinking, avoid stress, avoid extra salt, reduce intake of refined flour, maida, butter, cheese. So these are in one slide, in nutshell, what the antihypertensive regimen and what patients have to do if you have been diagnosed of hypertension. Then what about symptoms of hypertension? Normally does not occur, but some drugs like prazosin, if we are taking, they can cause hypotension, fainting, passing out, dizziness, upset stomach, blood, distorted vision, fast swallow, shallow breathing, and fatigue or weakness, feeling tired, confused, agitated. But post-COVID, we can find a lot of these symptoms. So please watch out blood pressure. So all these things, if you remember, I would be very grateful. It is a simplified talk. It is a very difficult topic, but I have tried to make it simple. And I would request Simao to uh, keep talking on such important topics every 3-4 months, so that we revise our 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 knowledge, scratch the mind. So all this, with all this, I finish my talk here and wish you a very happy Deepavali to come, Dashera and Deepavali. And these days, Ganesha festivals are going on. Happy Ganesha festivals. Chaturthi is over. So all the best in the memory of Dr. K.K. Agarwal. I salute him once more. And he was our good companion, good brother. We lost him, and salute to him. Thank you very much.
Thank you,
On
sir.
to Srion.
Thank you, sir. Thank you for such a wonderful presentation. We have some questions from our audience. If you like to take that up.
Yeah.
Sure. So, sir, the first question is, which factors may contribute to hypertension? Select all that can apply.
Oh, it's a big question. A lot of factors. I have said there are certain hidden factors. Like patient has got occult hypothyroidism, patient has got disproportionate stress, lack of sleep, smoking, and endocrine causes like sometimes adenoma in the adrenal gland, pheochromocytoma. All these conditions can make the case difficult to treat hypertension or resistant hypertension. So all these factors should be in our mind while the patient is not responding nicely. And when we give the first time antihypertensive, ask the patient to wait in the chamber for half an hour to 1 hour, and then see how the patient is responding. So all these factors should be considered.
Thank you, sir. The next question from our audience is, what blood pressure medication are safe in pregnancy?
I have told previously we were using now we are using labetalol, but previously we were using alpha-methyl dopa. Alpha-methyl dopa was for a long time considered very safe, but now we have labetalol. And sometimes we can add beta blockers, and very rarely we can add diuretics when the case is complicated with either preeclampsia or fluid retention. And if there is any cause to treat with hypertension, then we have to treat that cause, like, again, I would say thyroid, diabetes, anxiety, stress, all these causes should be treated.
Thank you, sir. That's all from our audience today. And I would again like to thank you for joining us for this wonderful session, sir. Thank you.
Thank you. Thank you very much.